Welcome to Past Medical History, a series brought to you by the BJCA in partnership with Wondr Medical. Through these conversations with the doctors who we feel have shaped modern cardiology, we hope to bring you their perspective on landmark events and their take on innovation and discovery. We stand on the shoulders of giants, and we hope their stories will interest and inspire you. I'm Nikhil Alawalia, and I'm privileged today to be joined by Professor Jane Somerville, who is widely credited with establishing the field of Grown-Up Congenital Heart Disease, or GUCH, as its own subspecialty within cardiology. She has figuratively and literally written the textbook on how to manage this complex group of patients. And for her hard work throughout her career, she was awarded the ESC Gold Medal in 2008 and the American College of Cardiology Distinguished Service Award in 2012. She continues to do life-changing work through her foundation, the Somerville Foundation, and has kindly taken time out to speak to us today. So on behalf of everyone watching, welcome and thank you so much for joining us today.
Thank you for asking me. I'm delighted.
So Professor Somerville, many of our viewers will only know cardiology as it is today, with angiograms and EP studies and MRIs, but you graduated in 1955 from Guy's Hospital and went on to be the surgical house officer to Sir Russell Brock. I was wondering if you could tell me a little bit about what cardiology was like then.
Tough. They don't have it so tough now, I must say. We had very little time off. If you were lucky, you might get an evening off once every week or so. Nobody wanted to stand in for the house surgeon to Sir Russell because it was tough. As a girl, there were no special favours to you or for you, but maybe that was all right. If you want to join a man's world, you have to behave like a man, more or less. You don't have to look like a man. But, you know, we had to work very hard. All this time off and off at 5 o'clock is a load of nonsense because you had to clock your patients and all of that. Yeah. So there are lots to tell you. Maybe it'll come out. I can't even think now, but it was fun. Really enjoyed every minute of being on the house and being a doctor and running around with a stethoscope around my neck. Great.
And you mentioned being a girl in a man's world. From what I understand, you graduated at a time when the medical school was 90% men. So did you feel that you had to outperform your peers, or was that something you were aware of?
Oh, yes, we were aware of lots of things. 9% of the medical students were girls, so different from now. And did you have to outperform? I think we always will have to outperform to ever get appointed anywhere. Actually, it's a bit easier now because they'll be short of labour if they don't appoint women. I felt as we were in a man's world, we had to sort of obey by their rules, more or less, that it wasn't the time to alter them, that we just go jollying along. I don't think you can enter, if you're a butcher and you decide to be a baker, I don't think you can use butcher's rules. That's what I felt.
Yeah, fine. And so I was wondering if you could tell me a bit about what it was like to work with someone like Sir Russell, because he's a mythical creature to people who are practicing today, but what was it like in reality?
Well, very demanding, and all the stories, you know, like we had doctor in the house were sort of true. You went along in a long retinue. The house officer would be at the top, but he was trailed by all these men from all these people from all over the world, and they would elbow you out if they could. And we had he had a very fierce secretary who was always getting me into trouble. He didn't like addressing women direct, so he would speak to the Ross. Donald Ross was the senior reg. So he would ask Ross why the houseman didn't do this, that, or the other. Sometimes Donald would say, I don't know, sir, I don't know, I just don't know. And he'd shake his head. He was very tough, very shy, quite kind, brilliant teacher, absolutely brilliant. You never stop learning. So you had to put up with whatever you got, no good complaining. Yeah. Very slow operator. He used to say to Donald, why does my house surgeon wear earrings in my operating theatre? I don't know, sir. why has she got no shoes on? Because one's feet got hot in those disgusting boots. Oh, and all this went on, but he wouldn't address me. You know, why does my house surgeon, this was the worst, close her eyes when I'm operating? And Donald thought I was going to answer, and I was about to say, because it's such a bloody mess, but or something like that. Donald looked at me with rather triangular eyes, so I put my head down, no answer. So, I mean, you had to put up with all that. The girls today wouldn't understand how to put up with it. I mean, there was lots of anti-girl preached. He wasn't anti-girl, he was just shy. I can remember being in Guy's Hospital and crossing the park, which you know well, being a proper Guy's man, and Sir John Conybeare, the senior physician, arrived with his retinue, and he says at the top of his voice, I was crossing down minding my own business, "Oh, Christ, another bloody woman here." Can you imagine coming from school and hearing that? That's what you had to put up with. But I'd been to school with boys, so what the hell? I didn't care about that. I just put my turned up nose in the air further and walked past with all the tittering men. But I'd been to boys' school, so I knew what they were like.
Yeah. And so, I mean, the people you've named, Donald Ross,
Great
Brock,
teachers also.
yeah. What do you think make them great teachers? Because it sounded like they weren't speaking directly to you.
Well, all of them. No, Brock was a great teacher. You know, you still remember things like never let the sun go down on undrained pus. I mean, the fact that you can't find the pus, that's another thing. But there are lots of things. And Brock was an excellent diagnostician. Perhaps not the greatest surgeon, but certainly the greatest thinker. And they were very good teachers, and they were very clear thinking. Ross was a good teacher too, excellent, and a very good surgeon. Paul Wood was the greatest teacher of all because he linked the bedside physical science to physiology and what was known in science, and was an innovative thinker. That's why he was surrounded by so many people. So they were great teachers, so it stuck with you. They were the best teachers I had. You pick out if you like to be taught, and I like to teach. So I like to teach. If I had any juniors, I would practice to see what I knew. And I always liked that, even when I was at school.
What do you mean?
Well, I would teach people if they wanted to be. And I learnt that I had to read up to teach. So even before my ward rounds, when they wouldn't tell me what cases were in the ward, because I was expected to diagnose them at the bedside and then teach. But if I knew, I'd always just check what was known before, so I could catch up my registrars. Difficult. Some of them very smart.
Yeah.
But I like to teach, and the ward rounds were very big because people want to learn. And we had to be good clinicians because we didn't have all this amazing technical aid that you have now.
Yeah. And did you feel that there was pressure on you to get it right, or did you feel you could talk to the others quite openly if you didn't know something?
I taught myself and my group that you have three answers: yes, no, and I don't know. So I was an I don't know, but I do think that my firm, when I became a consultant, expected me to know. So you can't be I don't knowing too often. But you have to know when you don't know, or you have to withdraw sometimes when you don't know what's the matter with the patient and say, look, we better come back. I'm not sure what to do. You can't tell the patient too often you're not sure what to do, but you have to tell yourself or get help or something. And I think that's a very important lesson in life. You can't be expected to know everything, but you must know when you've got to ask for help, when you should say I don't know, and it's a very important lesson. But you can't do it too often in public, because otherwise people are not going to follow you. They say, oh, she never knows anything, So yeah, I was well aware.
And I mean, we've got a system now that is dependent on MDTs to an extent, which is good in some ways, I guess.
Oh, excellent. But the problem about we had MDTs very early. I don't know, we call them that. We used to call them meetings to look at all the patients and ask the surgeon and the radiologist and all that. I think the problem about the MDT is that nobody's responsible. And honestly, patients don't like waiting for the conference and being treated by the conference. They want their own doctor, and it's lost their own doctor. There isn't one person where the buck stops any longer. And I think that's bad. But to call in all the brains is excellent. But somebody, in the end, has got to be responsible between the patient and the doctor and the consultant. And this is what's wrong with the system now. And the patients feel it. They're always waiting for the result of the MDT. But where's my doctor? What does he think? It's not good.
So you've mentioned these scenarios when we didn't know what was going on. Can I ask, was that a part of your decision to manage these patients that were in this grey area between children with heart defects and adults?
Well, two things conditioned that decision by me to make that service. Because I was interested in congenital heart disease, trained as an adult cardiologist, so you can see there was a bit of mix-up there. But it became very clear to me as a surgical house officer that there was so much abnormality in the heart. And this nonsense of talking about total correction was a dream, not a reality. So what happened to the patients became a slight obsession to me if they did leave the hospital, which wasn't all that common, but occasionally they did, and occasionally there was a good result, and occasionally wonderful things happened. So that was the first thing. The second thing is that I couldn't get on the short list at the moment I thought I was ready. I think I was ready, overcooked probably, but I couldn't get on the short list of either paediatric cardiology, which was being appointed then, or adult cardiology. I was not acceptable to either, and I was the wrong gender. So I think I applied for 13 consultant jobs. By then I was married, so I was stuck to London if I was going to not take time away. But I applied for 13 and never got on any shortlist until I applied for the heart hospital, which I think was made for me. And you know, I went in to the House Governor's office and altered the advertisement. Can you imagine doing that now? It said, I don't know what it said, but I put it adult, I altered the title, Physician for Congenital Heart Disease, and it's very rare to have that. In other words, I could do congenital heart disease at any age. We didn't have infants in the heart hospital exceptionally, and I was an adult cardiologist anyway. So I just altered the title. I forget what it was on at, but I put Physician for Congenital Heart Disease, so that there was no age bar. No, but I had to. And if I hadn't invented the specialty of adolescent cardiology, in 1975 we opened an adolescent ward in the heart hospital that I'd raised the money for, so that people could come. I already was going to Great Ormond Street, and their adolescents were coming on. We knew there was plenty of, although they were surviving, there was plenty of need for proper cardiology, and there was this interim period.
Do you have an example of a particular patient that's in your memory that was not provided good care before your service came on?
Well, I can't say people didn't do good care, but I think that I wouldn't like to say it hasn't been good care, but there's been a problem about people who grow up with congenital heart disease, because there's been a long period where the paediatric people don't want to give up, and they operate this sort of parental view with no training to look after adults. Equally well, adult cardiology is not good at congenital heart disease and is very poor at adolescents. And well, they don't have any training, so they're very separate now, but in that time there were lots of examples of chaotic treatment because nobody had the thing. Nobody had the training.
How did you get the training then before?
Well, first of all, I was trained as an adult cardiologist. Secondly, I was spending a lot of time at Great Ormond Street since I was first assistant to Wood. And secondly, when I came into cardiology, we only saw adolescents and adults with congenital heart disease. So I had all that. I was trained in all that. And I went to Great Ormond Street with Dick Bonham Carter. It was very helpful. I had a session at Great Ormond Street that I didn't tell the heart hospital. I had a consultant session there, 2 actually, and then I gave one up to Bertie Wells, whom Dick Bonham Carter wanted to give something to. But so I always kept that all my time. I've always had a very close contact with them, and I saw all the advances and innovations, and they had excellent surgery, and they had survivors, and they were now surviving and needing adolescent adult doctors. So I got them. They came to me to look after. But then it was very difficult to get it going because of many obstructions. But I had to have a new specialty. Nobody would have me in what was available. So I thought, right, I'm going to fix you lot. I'm going to be the only one who can do this. I can remember making the decision as I drove back from Great Ormond Street to the Heart Hospital, crossing Tottenham Court Road and going up the street to get the west turning road. And I thought, the only thing to do is to form your own specialty. Nobody wants you.
Did that seem like a crazy idea? Or?
No. That's what we had to do. So we collected all these patients, and they were running around the heart hospital till the heart hospital said, yeah, we do need somebody who's dealing with it. What are we going to do with all this? So I was appointed in 1972, quite late. I'd been around a long time trying to get a consultant job, but a very good thing happened in 1968 is that the university, I was a senior lecturer to Wood, and the university decreed that all clinical senior lecturers would have consultant status. So I was half, albeit a second, albeit, as the dean of the institute said to me, you can't be on the consultant lecture schedule, this Aubrey Leatham. Why not? Well, he said, I don't have to explain, why not? You can't be. I said, well, I'm giving the lectures on and I'm a senior lecturer. Oh, no, he said, you can't be one of us. Nice. Can you imagine them saying that to a girl now? They'd be in jail. Jolly good thing too. I said, well, I'm going to be one of you, so don't speak to me like that. Flounced out of the office.
What happened then?
Well, your time came and, time came.
So I want to focus a little bit on your relationship with Donald Ross and what it must have been like to see that new procedure evolve. I mean, today it's done quite fluidly, but I imagine it wasn't at the very start.
Well, Donald Ross was waiting to do it, and he hadn't done there's a lot of experimental work going on, and there's no doubt Chris Barnard pinched Norman Shumway's ideas, but Norman Shumway, characteristically good American fashion, was doing cows and I think dogs, cows anyway, and dogs. I'm not quite sure what, but he showed Barnard, who'd thought it out. Barnard was a classmate of Donald Ross's, so it wasn't surprising that there was a lot of talk there. I think they were waiting to do it, but there was a lot to wait for. There was waiting for a donor to be right, and there was waiting for a patient, and then there was waiting for a match. The Heart Hospital was always ready. It was a great place for innovation, and Donald was very intelligent, so he was ready to do it. And Donald Longmore had thought it out in a sort of way, and he really organised it. Unfortunately, he had so much talk. He talked over the switchboard. So, of course, you can imagine the telephone operator staying on for that night told everybody. So we had the press outside, which wasn't very good. Taught the profession. Our profession was awful to us. They didn't approve at all, the people around. What do they think they're doing? And, you can't do that operation. Perhaps your greatest critics when you have innovations are your colleagues. Not your colleagues in the hospital, your colleagues outside. Terrible criticism from Great Ormond Street when we switched the first transposition in the Heart Hospital. They were, because they had a good operation. Terrible criticism from your colleagues. And I think Lillihei, who invented the first bypass, had awful criticism from the senior surgical colleagues. In fact, Dwight Harkin said, "How can you do an operation that might have a 200% mortality?" And so it's got to stop. It's got to stop when they did the first bypass, which was the father or someone transfusing the child. Not a machine. And that's why Lillihei invented the disgusting bubble oxygenator, because the surgeons of America said, no more of that stuff. Innovation is very troubled by envy and also sensible criticism. All innovations have been. Donald was very criticised for putting in a valve, and what's that? It's all going to wrinkle out. Awful. You've got to have surgeons of yesteryear, and I think now, have to have the courage of their convictions. Now, you asked me something else.
It
was a drama, I can tell you. 1968 it started, 8. It was a year of fine innovation in surgery in that year, because the transplant came. But, we lost a lot of patients with the early Rosses, because the operations were very long. The bypasses just wasn't great and destroyed the blood and this, that and the other. And patients didn't, the hearts, we had stone heart. That was ghastly. So we had a lot of losses and a lot of goings on and a lot of hemorrhage. It was a nightmare. I was the sort of handmaiden physician to the surgeons when they wanted something. So I spent I really don't know how I had any home life, because by then I had 2 or 3 children. I don't know, a nanny, and certainly wasn't my husband looking after them, that's for sure. I suppose we managed, but we had a lot of adventures in those first. I don't know whether I should put everybody off by telling them, but we had, we bled 160 people one night. We had the local police station of Marylebone out. You didn't have all this busy cross-matching. You had to make sure they were the right blood group. And I suppose they tested for something, but not surprising that a few people got a few diseases. But we bled 160, including the local police station. They were coming in. We had to check their blood group. Chap bled so much, but he lived. That chap lived. And then we had the Night of the Pigs, which nearly destroyed the surgical service, because we had one of these stone hearts, young person. Donald couldn't get off bypass, and the heart went into just a stone heart, too much calcium, I suppose, or whatever it was about. So this very bright spark, Donald Longmore, who controlled the bypass, said, "I've got an idea. Why don't I get pigs? And we see if we get live pig hearts in." Well, it all sounded good, and anyhow we were desperate because we had to take off the bypass. Unfortunately, the pigs arrived in a sack, got out in the mews by the heart hospital, squealed as we were all running round trying to catch piglets in the middle of the night, and woke up the matron. And anyhow, we got the pigs in and we got them onto bypass. Not me, I didn't, and the heart went black. It was quite ghastly, the things that went on. No ethical committees, nothing. But the matron complained to the senior physician, a Barts man, the senior physician who stopped all surgery. She said, "I was woken in the night." And then the stupid Donald Longmore sends her pork chops for her breakfast. Can you imagine? We all said, "Well, you're daft, But these sort of things happened.
So now, Professor Somerville, I just want to focus more on your experiences as a woman in cardiology. You have gone on to achieve so much, but also had a large family with 5 children. Four. Sorry, a large family with 4 children.
Well, I think I was very lucky, and I say to the girls of today, be careful who your partner is. Be careful in the choice of partner, because we choose our partners at a time where we're probably not very perceptive as to what we want and all that goes with it. But anyway, there are lots of issues about that. I had a good husband who didn't want me ministering to him too much, and he had enough money because he was a consultant who worked hard, so that I had a nanny and a housekeeper. Having decided I wasn't going to do any of that domestic stuff, and he was quite happy with that, I also made it clear before marriage that I couldn't, I had to do medicine. I had stars in my eyes for that. I wasn't going to iron any shirts or anything like that, and didn't. I did iron a shirt once, it was a disaster, and he got a iron burn in his favourite shirt, so that was that. They went to the laundry or whatever after. So you have to have time, and we have our great enemy is fatigue. Women get much more tired. I think men are more resilient in that respect. And one does get very tired and emotional and all that stuff, but you have to put up with a lot of criticism. What's that? May make you better. And it's very hurtful sometimes. Very hurtful when you don't get positions, very hurtful when you don't get appointed, or perhaps you want a decoration you don't get. Oh, it happens all the time. And I've even been subject to criticism, comment, rude, since I retired. I'm no threat to anybody, but I think I was a bit of a threat because I was quite mouthy. That's not a good thing to be.
Yeah. And it sounds like when you were a junior trainee, people criticised you to your face and didn't hide the fact that they didn't approve of you being a woman. Do you think things got better as you moved up the ladder, or do you think it just went silent?
By the way, this is a very sexist country. Don't have any illusions about that. They can be politically correct, but they're meeting in the bar, getting all the rest, What did you ask me? Do I think? Well, they didn't always criticise you to your face. That was one of the problems. They're easy to manage if they criticise you to your face. Boys don't generally do that. Girls will, but boys won't. It's all, political correctness now. So, but I don't think you know the half of the criticism that goes on. So I wouldn't like to get into that one. But it's tricky. But there are faults on both sides. I do have to say, how did I manage luck, resilient personality, a good husband that put up with a lot of carry on, and I think those three things. I had a good memory too. That helped. One could remember the answer even if you didn't understand it. That's always been very useful. I remember my colleague at one of these MDTs, they were sort of meetings with all the senior staff present in the heart hospital. And my colleague Edgar Sutton, who I rather liked, they were talking about a case of something or other, it doesn't matter. And I said, I don't think it's like that. I think it's something else. They were all presenting. I think they were talking about Wolff Parkinson White or something I didn't really know much about. And I was right and the others were wrong. That's not the point of the story. And Edgar Sutton said to the assembled company, don't take any notice. She just works by instinct, not by knowledge. Well, I was a bit taken aback, so I think that's the time I didn't answer back, but I thought, what's my instinct worse than your lack of knowledge? I think I mumbled something rude, but I was quite hurt by that. Probably was instinct now I come to think of it. One has to put up with things, and it's no good getting huffy about those things. But I remember that was an incident which was hurtful. Probably damaging too, with all the senior staff. But anyhow, you can't be worrying about those things. As soon as you get home, if you have a good home and so forth. It was the amount of work was rather troublesome. But with all that help, I suppose, I wasn't domestic.
What advice would you give to a cardiologist in training who wants to try and do something that they think may be too much or a bit too innovative or something that they're anxious about?
I would beg you all, juniors, I would beg you all, do keep your clinical skills. I was taught clinical medicine very well in Guy's Hospital. Very well we were trained. I don't know how you're trained, but half the juniors I was meeting, say, up to 10 years ago, were a disaster. They couldn't diagnose a fig from a banana. They were so unimaginative and unworking. But if you came into medicine to do medicine for patients, please keep your clinical skills. Patients like talking to the doctor, not for too long, I would think, but please keep them and be able to examine. The texts do break periodically, and then you're stuck because you can't make a diagnosis. Keep them if you want to be a doctor. If you don't want to be a doctor, that's all right. If you want to be a radiologist or an echocardiographer or whatever, but if you want to do medicine, speak to patients and like patients, you've got to keep your clinical skills. Very poor clinical skills are available now.
One thing that you did that I think is really interesting was you spent a lot of your formative years in the operating theatre, and you would go to necropsies and see the anatomy. Do you think that was...
I think it was the most helpful thing I did, was being a house officer for 6 months. Not only do you begin to understand surgeons, which after all we needed to, they were our main therapy, they're not now, but also one saw anatomy. And that's very important to have a living thing in front of you as to what that heart is doing. It made a huge difference to me. And I think 3 to 6 months with the surgeons or the interventionists as students or in training wouldn't hurt you, even if you don't want to do either. I think it's very important.
And I guess seeing the pathology, like the asymmetrical septal hypertrophy, stays with you.
Oh, yes, it does. Honestly, it does. Well, there aren't necropsies done now, which I think is one of the mistakes. I think they'll have to go back to having the pathology, because you don't know if your interpretation of imaging is correct. There's a blah, blah, blah. It's a blah, blah, blah. It's a there. They don't know if it's correct or not. You don't know if you're right. And they're not necropsies done now. It's very bad. Yeah. Even the coroner doesn't seem to want them very much. It's very bad. You need the correction factor.
Yeah, that feedback.
Yeah.
And now looking forwards, where do you see the future of cardiology going?
Well, I imagine more and more technology. Valves will be made so they can be replaced. Rhythm business will get better because it's very techy. I think if you're not careful, you'll give up being doctors, which is sad, because cardiology is still part of medicine and very important, and people have brains and feelings, so I hope you won't give up that. I think most things in cardiology will be solved. Prevention will become much more active, but you'll still have cardiac cases and plenty of them.
And what about particularly for congenital heart disease? What do you think the future?
Well, I think the future for congenital heart disease is mainly prevention, mainly getting better surgery earlier, or better management earlier, it may be intervention. The intervention may be surgical or technical, catheter. I think there'll be more and more of that. Fortunately, paediatric cardiology still requires you to be a clinician. It's no good. You need to look at the patient. It's no good asking the machine to tell you whether it's ill or not yet. Maybe that'll happen. But I think prevention, intervention, earlier diagnosis, possibly more fetal. I don't know. Possibly more fetal, depends what the country can afford.
And so finally, what are you focusing on today?
I'm not licensed to kill anymore, so to speak, because it was all too much. And I think there comes a time where, it doesn't stop patients consulting you all the time. I have a principal interest and a principal enthusiasm to do one thing before I leave the planet, if I'm able, and that's to help the medical whistleblowers. I think unless something is done, unless these trusts are drawn in and controlled, it's going to be awful, and young people will leave the profession. They won't want to come and work in half these trusts. They're so appalling. The management of whistleblowers, young doctors in training, is absolutely appalling by many trusts. They're unjust, they victimize, they harass, and they bully.
Okay. Who do you think needs to lead this change then?
Well, the problem is that the trusts don't have to report to anybody, so they can spend, as they did in the unfortunate Christet, I think £750,000. He couldn't have money to do that. So somebody's got to discipline the trusts. Somebody has got to say whistleblowers must be judged independently, not by people the trust. There's corrupt tribunals. I could name it, but I don't want to. I have the courage to name corrupt tribunals led by corrupt people who are half in business, half doing this tribunal interrogation. Appalling. There's a young doctor, female, has got all the characteristics to be bullied. Female, small, Asian. This is in the public. I said this. Are we surprised she got bullied? They finally got rid of her with no grounds at all. What were the grounds for getting rid of her? Not fit for purpose. What is not fit for purpose? We can't get it defined. It's usually a thing in law which applies to instruments not fit for the purpose, not to humans. We cannot get it defined. She's lost her job. Consultant. So unfair. But there are many more. So you young people, you have to have somewhere where you can report it that's not in the trust, because they are not suitable to deal with it. Not all the trusts, but many. I think it's appalling, and you have to fight it. You will have to come and fight it. You will have to stand by your colleagues, but you're frightened of losing your job. One the other day lost his number. He was in training. Lost his number. They managed to get rid of it. I mean, if you've got that sort of thing going on, we are not going to keep a good standard of junior doctor to train as good consultant. That's what I would like to help, because you're all worth it.
Great. I mean, all the best with that, and a really important cause. And once again, Professor Somerville, I just want to say thank you on behalf of everyone at the BJCA for giving up your time and sharing all your wisdom with us. Thank you very much.
Not wisdom, but I've loved it. Thank you.